The bone you sit on when you're in a chair. You think you got it?
I don't want to press hard.
Right. Right there. Right there.
Yeah, so it would be right there.
Yeah.
Okay. And there's a nice solid bone right there. And you've got 3 major tendons coming off of it. So what 3 muscles are coming off of that location? Yeah.
It's like right here, like.
Yes.
You just have to. It's like right there. It's like right.
Yeah.
She went straight in there.
Yeah. No, you're all right.
So, distal tuberosity, what 3 muscles come off of it? What muscle group? Hamstrings. What muscles? What 3 hamstring muscles come off of it? Almost. Biceps femoris. Long head, thank you. So, semimembranosus, semitendinosus, and biceps long head come off of that spot. Where does biceps short head come off? About mid-shaft of femur and on down. So, biceps femoris is going to come lateral to the LC to the head of the fibula, and then semimembranosus, tendinosus are going to come to the inside of the knee. Tendinosus goes to pes anserine. Membranosus goes to the groove of the semimembranosus on the tibia plateau. All right, so those muscles. Put your finger just distal, so you're not grabbing tissues anymore, and have the person extend their leg. And you can feel those muscles fire. So what I want you to do is actually, so come right in here, middle of the thigh, have them extend, come straight up. And what I want you to identify is the muscle groups between biceps femoris and the semimembranosus tendinosus. When it's up high at the origination point, you can't really discern the difference. But about midway down, you can start feeling where they kind of split to go into the popliteal space. So you can really get a feel for how those muscles kind of move, or how their direction flows around the knee space. So lift up, and now palpate right through the middle, and you'll start finding where it separates. There's a muscle mass right in here, and then you'll find the other one coming out that way. So you're going to try it? So lift up, so palpate down, and what you'll do is you'll find a pretty good muscle mass. It's there. So you got this muscle mass right through here, semimembranosus tendinosus. So you've got that one ridging right through there. I'm just going to excise this a little bit. So lift up for me. Good. So you can grab right in here and really get a feel for the semimembranosus and tendinosus. And then the other one you can get is on this side, which is going to be your biceps femoris. So you can actually feel where that muscle contours, because they're going to split and insert down in here. So they're going to have an open space into the middle.
I think you were like the only one who wasn't in pain.
It's like an awkward. It's like an awkward thing.
You can feel that ridge. That ridge is kind of that border between the 2 muscles.
I was like, hold on.
It's like I know this stuff, but then like once he asks this question, I'm like blank.
Because you have to like really think about it.
Yeah, if you give me like 5 minutes, I'll
I'll be back in a second.
Now, where you find that location, where those muscles separate and split apart, if I were to say find right above that knee, feel right where those muscles separate, and then drive a finger in there, what structure am I digging into? What structure would I be digging into? That's the popliteal space, which is behind the knee. So what structure is it that kind of arises right in between the biceps? The plantar will start a little bit below that, but we talked about it just a minute. Sciatic nerve. Sciatic nerve. So if you cramp, now some people have sciatica, which is inflammation of that nerve. That's something that's indicative of a positive test. So if I drive a finger in there and that's what's hurting, then it's gonna reproduce some of their symptoms potentially.
So it's like between those muscles.
Yeah, so it'll be like these come down, they separate here and here. So sciatic nerve is gonna be like right in there. And it's actually gonna be that length. But the common perineal is gonna split off right up in here, and that tibial will run right down through there. All right, so let me get you guys to flip back over, please. So, you are. Femoral artery, nerve, vein. Nerve, artery, and vein. So the navy, the femoral navy, goes through what?
Femoral triangle.
The femoral triangle. So what are our borders of the femoral triangle?
Inguinal ligaments.
Yep. ASIS, in across towards the pubis, we have the inguinal ligament.
Rectus femoris and vastus.
Nope.
So it's inguinal ligament. It's one of the vastus.
Nope.
Starts with an S. Yeah.
Sartorius.
Sartorius. And then
Sartorius. It's like a
and then what's the third one though?
And the third one is adductor longus. So inguinal ligament, adductor longus, and then sartorius comes down and across. So it leaves you an open area right in here. Okay? So what can we do with that? So we know that the femoral nerve, which is the nerve that takes on
I got scared.
quadriceps. Okay, so which innervates the quadriceps. So the femoral nerve comes down, and then we have the femoral artery and the femoral vein. So the artery for sure is something that's good to know because we can assess for the pulse off of that. Now when you're checking for pulses, you never want to use your thumb because it has its own pulse and it can distract. So fingertips work well, and you can actually feel in there to find the femoral pulse, potentially. But you're dead.
Well, I have no heart.
The science experiment that you are. Okay, so pulses that we're going to have, and for the practical exam, we do lower extremity, we'll do dorsalis pedis, which is on the top of the foot. We'll do posterior tibial, which is on the inside of the medial side, behind the malleolus. It's potentially possible to go for the popliteal artery, which is behind the knee. That's a little tricky. Femoral artery is more common, excuse me. And then there's actually the abdominal aorta, which you can feel quite distinctly if you go above the belly button. And then push, you can feel that pulsing. Even though it's sitting pretty much on the level of the spine, you can feel the reverberation come up to you.
Well, which pulses?
Femoral. Femoral artery, femoral pulse. Got it? So, this one and then those two for sure are going to be of importance. Okay? So let's do some manual muscle testing so that we can get a feel for what that's going to look like. Manual muscle testing. We have a grade scale of 0 to 5. 5 means that they have full strength against full resistance. So anything I give to her, she can handle and kick it. Not a big deal. 0 on the other end is that there's no evidence of a contraction whatsoever. A touch of a problem. So then we get in the middle stuff. So that's 5 is full, 0 is 0. And then 1 means you have a trace. Like if your hand's on it, you can feel some muscle contract, but it's not enough to move the limb. 2, the limb can move, but not against gravity. 3, the limb has the strength to move itself against gravity. And then 4 is going to be a very hairy kind of gray area of you can apply some resistance, but it's not full. Now, how do we assess what that means? What is full resistance? What is some resistance, but not full? What are we comparing it to? Not so much fatigue. Again, it's about direct resistance on these tests. So, how do I assess the integrity of this leg? Of one leg over the other? I compare it to the other leg. I mean, so we potentially have an injured limb, and we're trying to assess its integrity, how strong it is, how good it is. So we're going to compare it to hopefully the other side, which is uninvolved with the injury, ideally, right? So anytime you do these tests, and this very much counts on your oral exam, you assess these things bilaterally. And then you grade them and say, okay, hip flexion, left side, 5 out of 5. Hip flexion, right side, 4 out of 5. Now, obviously lifting against gravity at a 3 out of 5, and then full resistance at 5 out of 5, there's a lot of range in there. So you'll hear people use like a 4 minus, a 4, a 4 plus, based upon kind of how their comparison is. But there's a little bit of a gray scale within that. So let's kind of look at what some of these tests are like. So slide up for me. So we'll do hip flexion first. Hip flexion is just lifting that knee up, that leg up. So pick it up, and you're going to push down. And then check the other side. So 5 out of 5, both sides. So hip flexion, very easily, you can have them seated and just lift up. How would we move her to assess for if she didn't have full strength, if she couldn't go against full range of motion, or she couldn't go through against gravity? How would we position her to then assess that? If she can't lift it against gravity, how do we assess that motion, but taking out the influence of gravity? What's that? Yeah, sure. Well, lying on her back, or what position lying?
On the side.
Side. We put her on her side, then she's now lifting it sideways, perpendicular to gravity, so it's not influencing. You see? So this isn't so much about memorizing that manual muscle testing book as it is really, if you just understand the motions, we can usually come up with logical solutions that get us there. So, hip flexion. So knee extension, very simple. Just stabilize one hand and then extend your knee. And we're just going to hold resistance. And then try the other side. And that's like a 2.5 out of 5. I didn't want to kick you in the face. Okay, so that's knee extension. Knee flexion, we can just do the opposite to where she's pulling back. Good, and then we go to the other side and compare, and we're going to get 5 out of 5. So, internal external rotation of the hip gets a little weird. So if I extend her leg, and I ask her to externally rotate, her femur is going to externally rotate. Her foot is going to externally rotate. Relax. If I bend her leg and ask her now to externally rotate, then she's bringing the foot up and in. So external rotation of the femur is actually pulling the foot across the midline of the body. So if I'm going to strength test this for external rotation, you want to brace against the medial side. Now push in. And that's checking my external rotators. And if I want to do internal rotation, push up. That's going to check my internal rotators. So this is the one that's kind of opposite. It's it bothers people sometimes. But if you just remember that if you're here and you external rotate, it looks different than if you're here. So you can figure that out. Hip flexion, extension, knee extension, motion. Love it. Abduction, adduction. So, you on your side, please. So we were talking about hip flexion outside of the influence of gravity. So you can put her in this position, relax. You can actually cradle some of the weight to take the pressure off the adductors, or the abductors, pulling it out, and bring your leg forward. No, bring your hip forward, flex your hip. So then you could have her move it through a range of motion without gravity involved. Okay, so in this position we'll do abduction, adduction. So here, abduct your leg, lift your leg up. There you go, and then just you can do muscle test. Then we'd have her switch sides and be able to grade that. Adduction, I think the easiest way to do it, relax. Put you right there. So cross that leg up and out of the way, and now she can do a straight leg raise this way. Adductors, and then you can push and resist. Now, a very cool thing about manual muscle testing is it teaches you enough about body position that if you want to start rehab, you're giving them evidence of really some of the entry-level exercises. So what we want is typically to have high repetition, low load. Well, body weight is typically low enough load that we can get them to do high reps of it. So if I need her to then work on abduction exercises, then I can say, okay, one of your first exercises tonight is lift this leg up 20 times in a row, do 3 sets of 20. Again, we're just trying to get blood flow to those muscles, but it's based upon manual muscle testing, pretty simply. Just isolating the action of that muscle. Okay? Now, paying attention to